Thanks so much for inviting me to speak, Monica and Arena. I'm going to be covering retinoblastoma today and giving a clinical update. And I've organized my talk into two sections. The first will be on diagnosis for the first 10 minutes, and then the second 10 minutes will be on treatment. And I really want to go into some detail today and really cover some things that may not be in the literature. So this is the classic differential for leukocoria that we teach all of our residents, and I'm going to spend the most amount of time on the three really vexing differentials that confuse us clinically. That's Coast disease, PHPV, which is now called persistent fetal vasculature, and then Astrocytic Hamartoma. The other entities are easier to rule out in my experience. Now, when you read textbooks, and I wrote this textbook for Arun Singh a couple of years ago, there are lots of clinical features that are listed, and it's really hard to know which ones to rely on because in clinical practice, it's really rare for a patient to have a classic presentation. Often you have confounding clinical factors that suggest one versus the other. So I want to emphasize some clinical signs that are more important than others. But I will say that in some difficult cases, I follow closely because I cannot always tell. Even though I consider myself experienced, I see a lot of cases, even I can't tell sometimes. And then if there is a patient where I'm just not sure and the visual prognosis is dismal, I have no problem, and the other eye is normal. I have no problem doing an enucleation as well. I tell the parents that I may be wrong, but it's just too dangerous to keep the eye. Now, I see a lot of patients in clinic for what's called pseudoleukocoria, where the patient has nothing. And I'm more than happy to give good news to the parents. This is a pretty common thing that's referred into our office, and I'm sure many of you in the audience see this as well. Not exactly sure what causes it. We think that maybe it's the optic nerve that's causing this sort of reflex. Not sure if this has a laser pointer. You can see on the right side there, that's a patient with pseudoleukocoria. And often the eye is turned inward, and we think maybe it's the optic nerve that's getting the reflection. And maybe it looks a little bit different than the real patient with retinoblastoma, as you can see on your left there. It tends to look a little bit more dull, I think, when they have real retinoblastoma. But sometimes I see photos where the eye is not turned in, and it looks whitish, and I'm more than happy to examine the patient. So here's what I do in the office. This has worked in my hands. I'm open to changing it, but until I miss one, this is what I do. So first, I take a history. Obviously, you have to find out if there's any family history of a serious eye disorder, any blind eyes that were removed, any family history of retinoblastoma. I do a dilated fundus exam. Typically below age 1, I do a speculum exam. Just explain to parents that it looks awful, but it's safe for the child. And the older kids, usually I can get them to cooperate to get some kind of view. But the most important thing is that you have to do a B-scan in the office. I think it's a real mistake to not do a B-scan. It's extremely unlikely that retinoblastoma is the cause of the leukocoria and you would miss it on a B-scan. That is almost really hard to imagine that that would be the case. Now, B-scan doesn't find every tumor. So in my experience, if a tumor is 3 millimeters or smaller, you can definitely miss it. Sometimes I have patients coming in with unilateral RB. It's very obvious in one eye. I look at the other eye. It looks normal on B-scan. When I do the EUA, I find a small tumor, 2 millimeters or so. If it's 4 millimeters, I usually will find it. But there are certain situations where the B-scan is not reliable. So, for example, if you have a positive family history, obviously, even if you have a normal B-scan, you have to do an EUA. So these are my indications for EUA. Positive family history, for sure. Parents have history of retinoblastoma. Chances are 50% every child. You have to do an EUA in that situation. Any suspicious findings on the exam? If I see anything that might suggest RB, of course, I have to do an EUA. And then finally, the totally uncooperative child. Now, I would say in most instances, if I have a good B-scan exam, and you may have to hold the child down to do that, if I have a pretty good B-scan, I feel pretty comfortable not doing an EUA. But if there's anything suspicious, or if the patient's referred in by a pediatric ophthalmologist, I know that they saw something. In those situations, I usually will do a B-scan, or EUA, sorry. So what are some clinical features that are most reliable? All these things can be produced by retinoblastoma. Some of the things are kind of surprising. Subretinal lipid, you've never seen that reported, right? Never seen that described. I can tell you it happens. Crystals, dislocated lens we talked about earlier. What is not seen, though? Retinal traction. Untreated retinoblastoma never gives you traction, and you never see a cataract with an untreated retinoblastoma. What are some helpful signs? Calcification is number 1. If I don't have a view, if there's any calcification, I have no problem taking that eye out because in my experience, that's a dangerous sign. They say Coast disease can cause some calcification. I really haven't seen that. So calcification is really important. Also, any tumor that's big enough to cause leukocoria is going to have seeding. So if you have a view, that's a very reliable sign. So let's talk about Coast disease. Often these patients that have these confusing cases are males. They're usually unilateral, so it's very confusing. The history can be helpful, but not always. Often, the classic description of peripheral telangiectasia, subretinal exudation, you almost never see that in real practice. This is the classic sort of appearance with yellowish exudate, dilated peripheral vessels, what looks like lipid, but you often don't see that. This is typically what you have to differentiate. On your left is retinoblastoma. On your right is Coast disease. Now, it takes a lot of experience to differentiate the two. What I can tell you is that the telangiectasia looks a little bit different. The vessels are usually a little bit smaller. And also, where you have telangiectasia, usually on fundus exam, you're going to have tumor infiltration. You can see where that arrow is. That's what causes the telangiectasia, so look for that. Here's a patient that I saw when I was at Stanford. This patient was a 7-year-old boy, unilateral. The retina was completely detached, and there was clearly lipid there. That's definitely lipid under the retina. There was no solid mass. It's just liquid material under the retina, telangiectasia. So initially, I thought this patient had Coast disease. Other people saw the patient, thought he had Coast disease. But when the patient went to light perception, I took the eye out, and it was RB. So these are some of the clinical features that I use to differentiate the two. There are still some cases where I really can't tell. Calcification is important to see. Ultrasound is not as easy to see calcification as you might think. Sometimes you see these hyperechogenic areas. It's tough to make the call sometimes, and in tough cases, I'll do a CT scan if I'm not sure. Some of these clinical features, looking for that telangiectasia, seeding, retinal infiltration, take some experience to find that. MRI, I find not that useful to differentiate the two. Now, what about astrocytic hamartoma? Certainly, if you have the other signs of tuberous sclerosis, it can be easy, but in the younger patients, really all you have are the skin spots. The Ashley spot is really the only thing you have early on. So we look for those, but often you see these sporadic cases of astrocytic hamartoma where you can't really tell. I have to be honest, sometimes I just follow the patients because I can't really be sure whether it's a small RB or not. If you see those egg-like calcification areas, the mulberry lesions, that can be helpful. There are some OCT findings that can be helpful as well. But ultimately, I follow those patients because I just can't be sure. PHPV, if you read the textbook, it seems pretty easy, right? You have a unilateral, it's congenital, you have a microphthalmic eye, you have this retrolental membrane. If you have those elongated ciliary processes where it's sort of drawing into that mass behind the lens, that can be really helpful, but often it's not present. The stalk is helpful as well, but sometimes a funnel detachment can look exactly the same. So this is the differential that I came up with after being at CHLA for a while, because I would see these patients with these retrolental masses, and so I had to come up with a way of differentiating these entities. So this is what I came up with. So we have fever, which is just purely isolated ocular findings. So they have no systemic findings. You may have some family history. Sometimes it's asymmetric. You may see non-perfusion in the other eye. But really what you see is just this mass behind the lens. IP, fortunately, is rare. We only see it in females. The skin lesions are usually apparent. Usually they get this rash, kind of bullate-like rash, which turns into hyperpigmentation later. So the systemic findings can be very helpful there. PHPV, as I mentioned, should be easy because it's ocular. Usually it's one side. You have microphthalmia. But I'll show you a case where sometimes you don't see that classic presentation. The Norreus disease is sort of like PHPV, but with systemic findings. Usually it's males only, bilateral. You can have both posterior segment and anterior segment findings. They'll have hearing problems and mental retardation. And, the spectrum is explained partially by this interaction of the Norrin protein and Frizzled-4 receptor. So Norreus disease has a well-defined mutation in the Norrin protein, some of the others as well. So here's a patient with bilateral findings. There's something behind the lens in both eyes. The left eye is actually ophthalmic, but the pressure is normal. So this is very confusing. Since this patient was a female, just ocular findings, ultimately we decided this patient had bilateral PHPV. That was our best fit. Okay, so let's talk about treatment now. So there's been a paradigm shift over the years. Back in the 50s up to the 1990s, we treated patients with enucleation for the more advanced eye and radiation for the less advanced eye. And then in about 1990, Linn Murphree went to London and saw that they were just starting to treat patients with systemic chemotherapy. So then when he came back to the United States, he started treating patients at CHLA with systemic chemo. And then all these papers started coming out in the mid-90s with systemic chemotherapy. So the strategy was to shrink the tumors with systemic chemo and then laser what's left. And then we would do external beam radiation for salvage, and we did that for many years. And then in 2008, I was one of the co-authors on introducing intra-arterial chemotherapy. And then in 2012, Francis Munir published this very important paper on intravitreal melphalan injections for vitreous seeding. So this has been the paradigm shift over the years. I feel as though I'm in a pretty good position to evaluate the choice between systemic and intra-arterial because I was there at Sloan Kettering when we started treating with intra-arterial, and then I came to LA and I trained with Linn before he retired, and he was sort of the father of systemic chemo. So I feel like I can give a balanced perspective on that controversy, which is really rampant right now. You know, we have all these options, but the real controversy in 2018 is whether to treat for primary therapy systemic chemo plus intravitreal or intra-arterial plus intravitreal. That's really the controversy. So systemic chemotherapy works very well. It's still a very valid therapy. And especially for groups A through C, it has a very high success rate. At CHLA, we give 3 cycles for group B, 4 to 6 for group C. But I would say most patients receive 6 cycles. It's a long therapy, 6 months. It's given over 2 days per month. It's surprising how well children will tolerate it. There are 3 drugs that we give. And you know, bone marrow suppression obviously is common. Often they'll get neutropenia, kind of depending on the cycles. But with 6 cycles, you know, a lot of them do get systemic, significant neutropenia. Most of them get transfusions, so patients should be aware of that. Parents should be aware of that. Ototoxicity, fortunately, is not too common. We've seen it in a few cases, especially in the younger age groups. There was a paper on secondary leukemia thought to be associated with the etoposide. There have been 12 cases reported. Now, this is something that we never used to see in the era of radiation, so maybe there's a link, but if there is an association, it must be very weak. But the bottom line is it's a costly therapy. It takes a long time, but there are really no ocular complications. And often we see very dramatic results. Not every patient responds this well, but we have a lot of success stories with systemic chemo. And you can see the success rates there. Now with group D, which is the most common presentation in my experience is group D, the success rate is only about 50%. And we used to salvage these eyes with radiation, pushing the success rate up to 75, 80%. And then for group E, for systemic chemo, it's not a very high percentage. So typically for unilateral group E's especially, we tend to do enucleation. So how does systemic chemo fail? Well, you could have a retinal recurrence that's too large for laser treatment. You can see in the top picture there is a retinal recurrence. And we see these pretty commonly, but if they're small, we can laser them. If they're too large, really out of options. Vitreous seeding, you know, as a group D, it works sometimes, but in half the eyes it fails. But ocular complications are pretty rare. We almost never see ocular complications for systemic chemo, probably because we're not getting the drug in at a very high level into the eye. So give you a little backstory on intra-arterial chemotherapy. When I first got to New York to train with Abramson in 2006, he had just gotten the IRB approval for this protocol. I still have this, to this date, have no idea how he got this protocol approved. There's no way it would be approved at CHLA. So he told the IRB committee, look, we're going to take kids that are 6 months of age, and we're going to take this catheter, put it in the femoral artery, guide it all the way into the carotid, do fluoroscopy, find the ophthalmic artery, and then use a very small catheter, and then infuse melphalan, which is a very powerful alkylating drug that we still use to kill bone marrow before bone marrow transplant. We're going to do that, and then we'll see what happens. So I'm still not sure how he got this protocol approved, but when I got there, he had just gotten it approved. So it was a pretty exciting time. And I think I was the first person to actually see a patient who had been treated, and you know, we didn't really know what we were going to see. I remember looking through the pupil, and we were surprised to see dramatic results. You know, it's hard to compare systemic versus intra-arterial, but my impression was that the effects were maybe more dramatic than with systemic. And we had 2 eyes that had persistent subretinal fluid that I think David felt compelled to enucleate them because he had taught me early on that if you don't have a good view and you can't monitor the eye should be enucleated. So I think he felt obligated, since I was there, to go ahead and take these 2 eyes out. But those 2 eyes didn't have any active disease. So it looked like the first 9 eyes were treated well. They didn't have any vascular complications. And one other thing I'll mention is these doses were calculated by Pierre Gobin without any empiric data. He just looked at the territory, the blood volume, and calculated it, and it's still in use today. I mean, it's still the same doses we use today, which I think is amazing. So the protocol right now is that we give 3 infusions a month apart. The usual doses of melphalan are about 4 milligrams. And it's interesting that a lot of these patients do get neutropenia, so we know that the drug gets out in the circulation. The real question is sort of the elephant in the room is how much of the melphalan goes into the brain? Because the catheter is not threaded that far into the artery. Because if you go too far, you get vasospasm. So it's held right at the ostium of the artery. So it's thought that some of the drug does go out into the brain circulation. And in these young kids, it's a concern. But success rates in treating group D eyes have been very good. I would say 70, 80%. Although if you look at this meta-analysis, it's been a little bit lower. And some series report even really higher success rates of 90%. So I would say overall the summary would be 70, 80% success rate, which is higher than the systemic chemo, which I mentioned was 47%. So there may be an advantage, although we haven't done a direct comparison. What are the complications? Well, you're getting drug at higher levels in the eye, so we would expect some complications. And there have been choroidal infarctions. Sometimes we see this erythema on the forehead. I just had a patient on Thursday with this type of side effect. It is transient. Most of these complications are either transient and not very significant, or they're very rare. There's been one case of a stroke, UCSF, in a patient with an incomplete circular bolus. And then I read a chart of a patient from Miami who had transient hemiparesis as well. So there are some concerning but rare side effects. The real concern is about metastatic disease. Are we exposing our kids to a higher chance of metastatic disease? This is really a topic we could talk about for hours because it's an ethical dilemma, and it's one that we can't really measure too well because incidence is pretty low. If you look at the meta-analysis, they found a rate of 4.4%, and at Sloan Kettering, they found a similar rate of 4%, but when they compared it to their patients who had undergone enucleation, they couldn't really find a difference. At CHLA, we have a less than 1% chance of metastatic disease. But again, at these really low rates, it's really hard to compare and hard to prove that there's an increased risk. But you might ask, why is there an increased risk with intraarterial? It's because you're treating more advanced eyes that would typically be enucleated. Also, you don't have any systemic coverage. So as you know, if you have a enucleation, you have high-risk features like post-laminar optic nerve invasion or massive choroidal invasion. We give systemic chemotherapy to clean up some of the cells which may have gotten out. For these patients that receive intraarterial, they don't have any systemic coverage. So if you think that adjuvant chemotherapy is effective, you have to admit that there may be some disadvantage for systemic disease when you give intraarterial. There are some centers that don't do any intraarterial. So at St. Jude's, Matt Wilson has published this primate animal model where during intraarterial, he took photographs and did angiography. You can see all this vascular toxicity from intraarterial, which we're not really seeing in our patients, we don't think. So if we were to compare the two, how does it really fall out? Well, I think for globe salvage, there is an advantage to intraarterial. The success rates are a little bit higher, and you can see the numbers there. But when we add intravitreal injection of melphalan, the rates are pretty similar, not that dissimilar. So I think systemic chemotherapy is still a viable treatment option, even though there is a slight advantage. For metastasis, there may be a slight advantage for systemic. Even though, again, the differences are difficult to measure. What about side effects? They're different. With systemic, we have to worry about transfusion, hearing loss, small risk of leukemia. It's a longer course. Whereas with intraarterial, we have more local side effects, more regional side effects. There's also some concern about the fluoroscopy utilized during intraarterial, which can be pretty prolonged, especially in bilateral cases. Okay, let's talk about intravitreal melphalan, which has really been revolutionary for treating vitreous seeding. A paper was published in 2012 describing this protocol. Prior to this, we were really afraid of going into the eye because of the risk of the cells getting out. But with this protocol, using a very small needle, doing an AC tap to decompress the eye, and doing cryotherapy, we have not seen any cases of extraocular spread. This is the first patient I treated at CHLA. This patient had failed external beam radiation, had a very good visual potential here. This is her only eye. Fortunately, the paper was published in 2012, and I convinced our oncologist to let me inject this eye. And I saw her just the other day, and she's 20/40 and has had no recurrence. So, thank goodness that paper was published. So this is kind of a busy slide, but it just shows you that we don't really know what the right frequency is for intravitreal. I think we're doing it usually once a week, sometimes every 2 weeks, up to once a month, but we don't really know what the right frequency is. The doses have ranged between 20 and 30 micrograms. Most of us have kind of gone lower, but success rates have been very high with this protocol. Again, no cases of extraocular spread. However, we have seen a few cases of retinal toxicity, And RPE atrophy is pretty common. We've had a few cases of this really profound retinal toxicity, and we're not really sure exactly what causes it. I think the scary thing is that we don't have any risk factors that are correlated. It's not really related to age or number of injections or total dose. So in monocular patients, it makes us very concerned that we may get this. So in summary, these are really the topics to talk about. For unilateral disease, we have the option of IAC versus systemic chemo. It really depends on the center that you're at, the age of the patient. So for example, if the patient's really young and the artery is pretty small, we would tend to treat with systemic. I think probably the sweet spot for intraarterial chemo is unilateral group D in an older patient. But I have no problem enucleating a unilateral advanced eye with poor visual potential. So certainly group E's or some group D's. For bilateral RB, I still think that systemic chemo is the way to go because you treat both eyes at the same time, you provide some systemic coverage, and often the bilateral patients are younger, so I think systemic chemotherapy is a good option there. For salvage, it really depends on what you use first. So if I use IAC first, I'll often try to salvage with systemic chemo and vice versa. But enucleation is a very important option to consider with the parents when the primary therapy fails. I think you have to have a discussion with them about what you're willing to put the child through to salvage an eye that doesn't see well. So if you look at the IAC series, only about 25% of patients have vision better than 2400. So, what are we willing to put up with to salvage blind eyes? And I'll just end by discussing sort of an ethical dilemma. So as I mentioned, I was one of the co-authors on the IAC paper, the original one. I've reviewed 3 cases now from across the country where children have died following IAC, and the story is always the same. Multiple sessions of IAC, even though it's really not effective. Loss of the view because of a hemorrhage or a cataract. No enucleation, continued follow-up with ultrasound or MRIs. Direct extension of the tumor through the optic nerve, child dying from CNS disease. So I think to myself when I read these cases, if we had never published that paper, would those kids be alive today? And again, 3 cases that I've read, I'm pretty sure that IAC was responsible for the death in those 3. Well, maybe it was a judgment of the clinician. I think those eyes should have come out when things were not going well. On the other hand, we've saved a lot of blind eyes. We've saved more eyes than we were saving 10 years ago. So I'll end there and take any questions. Thank you.
No radiation on that slide at all. It's radiation off your mouth.
Yeah, so, in 2012 with that Munir paper, we've really replaced radiation with intravitreal melphalan. The last patient we've treated with external beam was probably 3 years ago. I would still consider it, if it was a second eye, everything else had failed, before nucleating the second eye, I would consider it. Yes? Yeah, that's a dilemma because obviously if one of the parents did have retinoblastoma, the child would be at 50% risk and they would need really monthly EUAs.
Right, if it was a parent,
year.
I would send to you guys to screen. But what if it's an auntie?
Yeah, I think that in that situation I probably would examine in the office, doing careful exams in the office. Fortunately, in the early age groups, like first 3 months, if you have a new RB lesion, it's going to be in the macula, so you probably will see it on the office exam most likely.
Talk a little bit about genetic testing, parents and family history, and how to follow those patients if the genetic testing came back negative?
Yes. So we utilize gene testing in almost all the patients because it's really simplified how we follow patients over the years. I think NGS, is available now, next generation sequencing, where we can really sequence the whole gene. It's a big gene, so it's been really costly to test these patients. But there are some limits to gene testing. So if you look at the data from Toronto, in the bilateral patients, the sensitivity is only 96%. So there is a bit of a fudge factor. Even though unilateral patients negative, I still see them in the clinic because the sensitivity, even in bilaterals, is 96%. So it can't be any higher in unilaterals.